All right, hello everybody, welcome back. Hey, this time we want to put in some more work with endocrine, and we want to talk about insulin and diabetic complications. All righty, so I'm Cliff Davis. I'm Associate Dean of Nursing and longtime advanced medical surgical professor, okay? All right, let's jump right in. So, what are we doing at RN Cliff Notes? We are helping students to see through the larger concepts. How do we do that? You see that little triangle in there? It's got three sides. What are those three sides? We're giving you what? Study smart strategies. That's right. Help you cut through and see what's going on. Alrighty. So, on a sheet of paper or in your device, right? Number that from 1 to 4. All right. And very first question. What is the name of the hormone that increases the blood glucose level? Increases the blood glucose level, okay? All right. And what? Glucagon, yes. And to add to that, we want to ask, which of the following pancreatic cells produces glucagon? Doesn't that just roll off the tongue, right? Which of the following pancreatic cells? I like it, all right? Which one of these, all right? Which one would you pick? A, beta cells, B, delta cells, or C, alpha cells. So let's say that again for the folks who are driving. Don't look at your phone. Isn't that right? A, beta cells, B, delta cells, or C, alpha cells. Which one of those helps to produce the glucagon? And you should have said C, alpha cells. Fantastic. All right, number 3. What happens to the glucose after insulin is injected into the patient? What happens to that glucose? I think we talked about this in some of the earlier series. What happens to that glucose? And it is sent to the ICF, or the what? Intracellular fluid environment. Okay? Well, yeah, now that is a bit of a wake-up call for some people. Okay? It's sent to the ICF so your cells can use that energy. Now, number 4, if insulin sends glucose to the ICF, then what fluid does the glucometer actually test or measure? And that should be ECF, of course, as we can see, yes. ECF. So that measures ECF fluid. Fantastic. Right? Now, one thing to keep in mind, sometimes you're asked about fluid environments. And of course, anytime you're asked about the intravascular environment, we're speaking of the ICF and the ECF. What? The intracellular environment and the extracellular fluid, which are both inside the vein, which is the intravascular fluid together. Okay? All righty. So anyway, diabetes, all right, defined as a group of diseases that result in too much sugar in the blood, or high blood sugar, or as we like to call it, right, hyperglycemia. Okay, so here's that chart situation again. Like I said, it's very, very helpful when we're talking about endocrine to go ahead and label that hormone that we're talking about and study it in terms of what if that person gets too much of it, right? And what if that person doesn't get enough of it, right? All right. So here we go. So as you can see, if the person gets too much insulin, that can send them into a state of hypoglycemia. And in this case, the numbers that you see, we're speaking more to the diabetic client. In previous video, we talked about how we anticipate the normal blood glucose level to be approximately 60 to 120, right? Milligrams per deciliter. Now, that's for our client in a normal state that has no disease issues. But if our client's diabetic, then now you're going to see those numbers increase by a factor of 10, right? We want to the best of our ability, maintain their glucose level. So we're adding 10 to the typical normal range, right? So for hypoglycemia, in the case of the diabetic client, instead of 60, we're talking about less than 70 milligrams per deciliter. Okay, now, what kinds of things might we see when a person is having an issue with hypoglycemia? Now, typically, hypoglycemia, we need to take immediate action when the person's blood glucose goes lower than 54. From my own personal practice, I haven't seen a patient go below, I'd say the low 30s and not have terrible outcomes, right? Or survive. The low 30s. I've heard of patients who has gone as low as the 20s, and that person survived, thankfully. But yeah, at 54, we need to take immediate action, okay? Less than 54. So, hypoglycemia, what will we see? Shakiness. And I want you to pay attention to the fact that we highlighted shaky in red. Why? Because just remembering that shakiness that we anticipate in the client, it helps us remember our other symptoms, right? In terms of a mnemonic. So, shakiness, then the S, sweating, H, hunger, A, anxiety, K, kind of a play on words here, cardiac irregularities, right? So irregular rhythm in their heart. And then I, irritability, right? And then we got FP is kind of left over symptoms there, but shakiness, hypoglycemia, okay? And moving on. So the next thing we want to look at is hyperglycemia. Like we said, we increased it by a factor of 10 because we were talking about this on the basis of diabetes. So we're looking at greater than 130. But we tend to not see symptoms until this blood sugar gets much higher. So we'll take a look at that here in a second. All right, so here we go. So hyperglycemia, and what do we say? Greater than 180, we start to see the symptoms, and we start out with the 3 Ps, which are polyphagia. Let's stop there, right? We've heard of that phagia piece. We know that phagia means to eat, right? Like we heard about it in phagocytosis. What? Eating cells? That's what macrophages do. Macrophage, big eater, right? Macrophage cells, what do? Eat other cells, other pathogens trying to invade your body. So, polyphagia, a lot of eating there. So we see our guy in the corner there thinking about burgers and all kinds of stuff, right? And then polydipsia, that's where a person's very thirsty. Feel like they're thirsty all the time. So we can see our guy here, what's he got? Thinking about water too. And polyuria, right? Going to the bathroom a lot, okay? And we can see, right, he's thinking about all those things. But now, there's some other things that go with that besides the 3 Ps, which have to do with headaches, trouble concentrating, goes hand in hand with the headache, right? Blurred vision, again, trouble concentrating, fatigue, and weight loss. Now, to help you out with those symptoms, so the 3 Ps, got it, right? I mean, that's fairly easy stuff. Yeah, but this next piece, the headaches, trouble concentrating, the blurred vision, the fatigue, the weight loss, that might be a little bit more tricky in terms of remembering. But you watch it in Cliff Notes. So here we go. All right. And let's see if I go the right way there. Yeah, we go. All right. So here's what I did. So I took that H, right? The T, the B, the F, the W, and changed those to fit with the symptoms that we understood up here and had it match with the 3 Ps. So when we said the 3 Ps, polyphagia, dipsia, uria, what was that? Eating, thirsty, and what? Going to the restroom, right? Voiding, micturating, making urine a lot, right? So what? Eating, drinking, and toileting. So here we go. Our full bladder. So we've got what? Eating, thirsty, and toileting. Well, H, what? Hunger. T, thirsty. B, bladder. F, full of W, water. Hungry, thirsty, bladder, full of water, which matches up with the same letters off a headache, trouble concentrating, blurred vision, fatigue, and weight loss. Hungry, thirsty, bladder full of water. HTBFW. Okay, awesome. All right now, so back to our hormone chart. So the next thing we want to take a look at, other than what we've talked about so far, right? We talked about the hypoglycemia, we talked about hyperglycemia, but now we want to address what if hypoglycemia gets worse? What if the person gets too much insulin, right? Too large of a bolus or something like that. Then the person stands the risk of going potentially into insulin shock. And like we said, blood sugars can go dangerously low. And this is why you'll see many times if you're doing clinicals or you're in a nursing home or something like that, and you see that they're passing out apples and these cookies and things, you think to yourself like, hey, wait a minute, I thought the clients were, these clients are diabetic. Why are we handing out snacks, Well, the idea is this. Odds are higher that someone can be hurt by lower blood sugars than they tend to be by higher blood sugars. So you'll find that we're giving out those snacks and things like that liberally in the clinical setting, and that's the reason why. So in essence, we basically prefer the patient a little too sweet in terms of their blood sugar level as opposed to too low, right? Yeah. All right. So anyway, insulin shock. Let's take a step further. And on the other end, if they don't get enough insulin, they could potentially get to the point where they hit 360 in terms of their blood glucose level, and they run the risk of going into DKA, diabetic ketoacidosis. Now, this is something we're going to expound on in greater detail in the later video, okay? But at 360, they could potentially go into DKA. And in DKA, there is a such thing as potentially your client going into a DKA coma, right? Yeah, the blood sugar is that high, okay? A little further now. So we're doubling down on it, and this time we're looking at another incidence where a different complication, which in the past have been referred to as HHNK, but lately the name has been changed to HHNS. Now, so we're talking about hyperosmolar, hyperglycemic, non-ketotic syndrome. Now here's what I want you to pay attention to. In the previous discussion with DKA, notice that it was diabetic what? Ketoacidosis. Then check out this next one. This says what? Non-ketotic. Okay, so some of you are going, what the heck? Ketones, non-ketones, what's going on? All right, here. Basically, it breaks down to this. If you've ever watched Naked and Afraid, you'll connect with this, right? That's a pretty interesting thing to segue into, isn't it? We are talking about insulin. How do we find ourselves in Naked and Afraid? Okay, here we go. So anyway, you have to imagine, as we see those people in their initial photos, right? They're a lot bigger, and then later on, when they've lost like 20, 30 pounds, and they look so, gangly, what's happened? Their body was in starvation mode. In full-blown starvation mode, you have no carbs available, and your body, instead of processing carbs, your body actually starts to consume its own fat off of itself. And as your body breaks down fat, the result is that you'll wind up with ketones that'll start to show up in your body, because that's the byproduct of the processing of fat. As fat breaks down, that's where you get ketones to show up, and that's an indication that that person's in some type of starvation mode, like we see on that show, right? Yeah, but that's in the absence of carbs, right? Because anytime there's carbs, your body's going to process those first. But if you take them away, what, like an Atkins diet scenario or whatever it is, right? Then your body's going to start processing fat in the absence of carbs, starvation mode, right? So now, back to what we were doing. So we said that HHNS, we broke down the non-ketotic part, right? So there's no ketones. This is not a starvation mode scenario. But let's back it up a little bit. This hyperosmolar word, I want to make sure we catch that. So it's kind of tricky because we already said hyperglycemia. But I want you to realize that that's why we're saying hyperosmolar right now. Okay? When your blood gets to be really, really thick, right? When your blood's really thick, then we start talking about hyperosmolar, right? The osmolarity of your blood is like getting, especially in this case, is getting to the point that it's nearly consistent with pancake syrup. It's so loaded down with sugar and in the absence of insulin and things like that, that the blood is literally becoming thick enough to be compared to pancake syrup, right? Kind of a weird comparison, but you get the idea. Okay, so anyway, hyperosmolar, what? Super thick blood, right? And then why? Because of the hyperglycemia, the high sugar, right? And we understand that this is a non-ketotic situation, so the body's not in starvation mode. And then whenever we say syndrome, we know that we're ticking off like a punch list of things, right? Typically we're talking about at least 3 signs or symptoms when we say a syndrome, okay? So HHNS. Personally, I preferred the days of HHNK. I thought that K was kind of a dead giveaway to like NK, non-ketotic. But now there's more emphasis on the syndrome piece, not so much the K. Anyway, so what kind of numbers we're looking at? And we said just a moment ago what? The consistency of pancake syrup. Why? Because we're looking at, and hopefully you can see that in the video because it's kind of small print here, 1,400, a number of 1,400, right? And now let's think that scenario through. We're talking about something that is potentially fatal. And it's so important that you understand this because the untrained nurse will not investigate enough or thoroughly enough because you'll get readings back from your glucometer that'll simply say things like just HI, high, right? And to some nurses, that they may not realize the gravity of it, but if you have a patient that's in HHNS, and we're talking about blood glucose in the neighborhood of 1,400, your patient, even a healthy patient, probably has about 2 hours to live. The human heart cannot pump pancake syrup, right, for more than 2 hours without going into failure, right? So it is critically important that you as a nurse understand these different levels. And you're seeing an indication of high, and you're seeing these other symptoms in your patient, you need to act quickly, okay? All right, now, so by comparison, just in case you can't see it, so we did our hyperglycemia number. We just did that for a diabetic sense for greater than 130, which we understand that you typically don't see the symptoms till we get to about 180 or better. But DKA, we expected that to kick in when we got to about 360 in terms of the blood glucose level, and then for the HHNS, 1,400. Okay, great. Well, hey, thank you guys for tuning in and learning about these different complications and things. I think it'll help you out greatly in terms of your practice as well as your preparation for your licensure. All right, take it easy. All right, study smart.